Welcome to Lecture 5. In the previous 4 lectures, we've looked at some of the groundwork towards interpreting and classifying medical research. Today we'll start our first lecture in a series of lectures where we look specifically at one study design, and we'll start with randomized controlled trials. The objectives of this lecture are to 1. Differentiate the meanings of internal validity and external validity, so to know which is which and when internal validity is apparent and when external validity is apparent. 2. To describe the different methods of randomization and blinding that are commonly used in randomized controlled trials. And 3. Analyzing randomized controlled trials for the presence of biases and interpreting them for validity both internal and external. We've talked in previous lectures of how randomized controlled trials are the most effective study design for making a causal argument about an exposure and a clinical outcome. Let's look at this in the context of hypertension in non-Hispanic Black men. Look at this population because they're not usually enrolled in clinical trials and they're not usually linked to healthcare as well as some other populations. So we're unsure if pharmacists are able to help this population in an outpatient ambulatory setting. Looking at some other study designs that we could use to answer this question, it is apparent that randomized controlled trials are the most ideal. Case reports and case series cannot be used to infer causality. A case report in this setting would be if I'm a pharmacist and I saw a non-Hispanic Black man with hypertension and I gave him a medication and he improved. Well, it doesn't mean that he wouldn't have improved anyways, or a pharmacist is specifically useful in this setting. If I did a case control study, I could look at Black men with treated hypertension and Black men with hypertension that was not treated effectively and say which one of you saw a pharmacist specifically for hypertension, and then compare between those two groups. But again, case control studies lack directionality, so they might have recall bias and they might misreport whether or not they saw their pharmacist depending on their clinical outcome. Cohort studies would be better still, but they lack experimentation component, which is the most important causal criterion, and they can be prone to selection bias. So if I have 2 groups of Black men with hypertension and one group regularly sees a pharmacist and the other group regularly sees physicians, that might say something about the individuals involved in each group. Maybe the group that sees pharmacists has more advanced health care, better insurance. There might be other socioeconomic differences between the 2 groups, which is called selection bias. To avoid these, we're going to look at this topic in the context of an RCT and an important one for the pharmacy field. Before we dive headfirst into randomized controlled trial that's published in the medical field, let's talk about some definitions, particularly surrounding validity, blinding, and randomization. Just wanted to recap our hierarchy of evidence pyramid to start this lecture. We know that going from expert opinion up through case reports, through cross-sectional studies, through cohort studies to RCT, that the quality of the evidence goes up. That typically means when the internal validity of the study goes up. This typically means that the internal validity of the study will also be going up. But this does depend on the individual study, so we're always have to be careful with our interpretations. Well-done RCTs will have better evidence and higher internal validity than well-done observational studies. The best evidence obviously comes from pooling multiple studies together, and that's in the form of meta-analysis and systematic review, and we'll go and get into those in due time. Validity can be defined broadly as the degree to which the study's findings can be deemed correct or trustworthy. So if a study has high internal validity, you can trust the findings. If it has high external validity, you can trust that the findings to the extent that you can apply them broadly to other populations. So internal validity is the degree to which the outcome can be explained by the intervention. It answers the question, was this study conducted correctly and do I trust its findings? To have high internal validity, it has to do with study design, and it also has to do with conducting the study. So reducing bias to the highest extent possible, eliminating confounding variables, and making sure appropriate statistics are done to eliminate random error in your findings will all contribute to having a study with high internal validity. External validity, on the other hand, is the degree to which the study findings can be generalized to other populations or settings. And this answers the question, can I apply these findings to my patients? So let's say you read a study and it's done in Japan. Can you apply those findings to your patients, or are there systematic differences that limit external validity, even though the study might have good internal validity? It also answers the questions, do I expect these findings to apply to everyone broadly? So if I'm trying to treat a non-Hispanic Black man with hypertension, how do I want my study conducted, and can I trust the study to apply to my particular patient? Let's first focus on internal validity. To maximize internal validity, we must reduce bias so that the readers and scientists know the difference in our outcome, the difference in our outcome was based on the difference in the treatment or the intervention that we gave. This is what we've been talking about essentially for the past 4 weeks. One good way to increase internal validity is to have a direct control group so that when we know that the outcomes aren't due to the placebo effect, they're not due to regression to the mean, and they're not due to natural history of the disease, because we have a control group to control for all of these factors. That was in lecture 2. The second criterion for internal validity is the ability to randomize your patients. We want to match our patients between our control and treatment groups to make sure that they match up on all important baseline characteristics with no confounders present. You can also do this in observational studies, but the important thing in RCTs is that you actually are randomizing. Randomization ensures equal distribution of confounding variables that you know about, and even the ones that you don't know about, because if we're randomizing people in high numbers, then we should eventually balance out on every variable that could possibly or potentially matter between the groups. And of course, this limits selection bias. To have high internal validity, we want to ensure that the authors are using objective outcomes. If we use objective outcomes, it can reduce misclassification bias. So we have a very narrow category that's very thoroughly defined so that we don't misclassify one outcome into the other category. Then we can also blind participants and investigators to reduce observer bias so that no observer bias, no matter how unintentional, makes its way into our study and impacts our results. Finally, we need to choose our study population carefully. We want to exclude patients who could confound our results. If we have an aspirin trial and we're looking at how many people bleed on aspirin, we probably want to exclude patients who have hemophilia, who might bleed for other reasons. If we have an antibiotic trial and want to see how effective they are, we might want to include patients that are immunosuppressed, like those patients with HIV or AIDS, who might have a different response to our intervention. Now let's talk about external validity. To maximize external validity, the population, setting, and treatment regimen must all be considered generalizable. Having a very broad, non-specialized population, treatment environment, and actual intervention must be able to be used in a lot of different settings and a lot of different populations. To maximize external validity, we would probably want a broad study population in which we'd include patients of many ages, many genders, and ideally patients from multiple centers in multiple countries. That way you know that your treatment is very broadly applicable and will have high external validity. For example, a study in VA centers often include just older men. This limits external validity because you might not be able to apply those findings to women or to younger men who haven't seen military duty. The study setting also impacts external validity. Studies conducted in general hospitals or community pharmacies may be broadly applicable to all study settings in the United States, but studies which utilize advanced medical equipment or treatment techniques like the new CRISPR technology you can only use that technology in a couple specialized centers, so this would reduce external validity. The treatment regimen should also be broadly applicable. In other words, is the regimen widely available, like a medication tablet, or is it simple to follow, like a single medication, so you don't have to be taking it multiple times per day, and that way you don't have to be super adherent. Those two factors would increase external validity, whereas very complex regimens might reduce external validity. There's also something we should be aware of in treatment trials, which is called the Hawthorne effect. This means that patients who know they're being observed tend to be more adherent to treatment. This occurs in studies when we're directly observing patients taking their therapies. They tend to do a lot better than patients in which they're not being directly observed. So if we're watching patients take their medications, the Hawthorne effect is in effect, and that could limit our external validity. The criteria for external and internal validity for maximizing these two types of validity seem to be a little bit in conflict. So often studies with very strict internal validity, meaning lots of criteria to be included in the study, tends to reduce external validity. Another way of thinking about this is that if you have many criteria to get into your study, then more patients are excluded, which means fewer patient populations are studied, which means that your results apply to fewer populations. I included this kind of crude smart art graphics, which shows that as you get very specific with your inclusion criteria, it increases your internal validity, but your external validity goes down. You get such a specific study that your results can no longer apply to more broadly to broader medical populations. Another component of randomized controlled trials that needs to be discussed is blinding methods. Patients and clinicians may be affected by knowledge of the treatment regimen, which can lead to misclassification bias. It can also lead to the placebo effect or investigator bias. Trials that are not blinded are called open label, which means that both the patients and the physicians know exactly who's on treatment and who's not on treatment or where the treatment assignments are. Single blind trials mean that the participants are blinded and unaware of their treatment, but the investigators know who's on which treatment. Double-blind studies are more ideal because neither participants nor investigators are aware of the treatment allocation. And triple-blind studies technically means that the participants, investigators, and statisticians are unaware of treatment allocation, which is typically the gold standard. However, many studies which state that they're double-blind are also technically triple-blind, but they usually don't use that terminology. I'm just including it to be thorough. Let's bring our discussion over to endpoints, talking specifically about objective or surrogate endpoints. Objective endpoints are endpoints which are measurable, which makes them ideally not prone to patient or investigator biases. Some examples of objective endpoints used in the medical literature are, for instance, the 2-minute walk test, which simply shows how much distance you can cover in 2 minutes. So you just start walking and we measure how far you go. It's extremely objective, easy to measure, and not prone to bias from patients or investigators. Death is about the most objective endpoint you can get, but there are other objective endpoints like pneumonia, which can be difficult to make objective, but you need specific criteria to define it. So pneumonia might be a positive chest x-ray and that you have signs of infection like a high white blood cell count and a fever. Surrogate endpoints, on the other hand, are indirect measures of clinically meaningful endpoints. Surrogate endpoints can also be objective, but they tend to be a substitute endpoint for something that you truly want to study. For example, if you're using a statin medication, you might look at LDL cholesterol reduction as a surrogate marker for heart attack. So heart attack is the thing that you really want to prevent, but LDL cholesterol reduction is very highly associated with reducing heart attack. If you're going to use a surrogate endpoint in a study, we need to make sure that the surrogate endpoints strongly correspond or are strongly associated with the clinical outcome, or else they won't be useful to us. There are other ways to classify outcomes in a medical study, primary and secondary. When we create a study, the primary outcome is the outcome measurement in the study, which is of greatest importance. This is the outcome that is used to calculate a study's required sample size, and it is the outcome about which your type 1 error rate applies. So you essentially have a 5% error to determine whether or not your primary outcome is significant or not significant. Your primary outcome is what the study is designed to assess for the most part. Secondary outcomes are additional outcomes used to evaluate additional effects of an intervention. These outcomes are not used to calculate sample size or power. Type 1 error rate typically does not apply to these particular outcomes, except in certain cases which the authors should specify. And they're deemed exploratory because studies are not powered to detect differences in secondary outcomes, although they may be very important. We'll look at some secondary outcomes for our blood pressure trial in a little while. Finally, the last terminology we'll look at in this first video is randomization, which is sort of the cornerstone of the randomized controlled trial, the technique that truly ensures that the groups are balanced as possible between our treatment and our control. The major types of randomization, which we'll talk about in this class, are simple randomization, which just involves either things like a random number generator, or you just give every patient who's in the trial of 1 or 2 and then determine your treatment group after that, or you flip a coin and say you go into this group, you go into that group. It's applied at the individual level. You can do stratified randomization, which randomizes patients into distinct strata so that there's an equal distribution of key characteristics. An example of this would be randomizing patients so that there's an equal number of elderly patients in two groups. So you might have two different groups, but then you have old and young, and you have an old person. So you say, okay, you go into this group, and the next old person will go into the other group, and so forth. And then the young people are randomized in the same way, so that in the end, your age groups are balanced. Finally, the last type of randomization that we'll talk about in this class is called group randomization or cluster randomization. Say that you have a new teaching technique. If you randomize specific classrooms, so like one classroom is doing a flipped classroom and then another classroom is doing traditional lectures, you're not randomizing individuals, you're randomizing the group. So cluster randomization is on a group level. It could also be like a hospital level intervention, for instance.